said, and we have to partake it, that you don't just sleep and wake up one day and develop coronary artery disease. It's very important to understand this basic principle. If you understand it, it will help you to evaluate patients very well. Once you pick up a patient, the likelihood that that patient will have coronary artery disease is very, very likely. So you don't just think that anybody who comes to you with symptoms suggestive of coronary artery disease have it. They have it because of risk factors. You should have risk factors. And the risk factors are expanding. We have the traditional ones that we all know of, hypertension, which is a big problem here, diabetes, dyslipidemia, family history, which we don't usually consider, and then habits like smoking, cigarette smoking. But we are expanding it, and we have things that cystenemia, increased serum uric acid, hyperuricemia, and then lack of diet rich in fruits and vegetables. They are all risk factors for coronary artery disease. We've heard a lot about the pathogenesis, so I'm not going to go into that. But the main thing is about atherosclerosis, which leads to development of plaques or adenomas. And we should also understand, we mentioned it, that the adenomas have capsule. To understand this principle, that we have two types of capsule. We have the stable and the unstable capsule, which covers the adenoma. It's very important in disease process. And as we will know later on, those who come to us at the emergency, with emergency part of coronary artery disease have that in most cases because they had an unstable capsule which ruptured and led to acute thrombotic occlusion. So we mentioned this, and I want to be emphatic again that yes, you need the risk factors, but in the presence of risk factor, you don't also wake up one day and have it. It takes years. In fact, for somebody to move from here to this part, it takes an average of about 10 to 20 years in the presence of risk factors. So when he presented his case that he presented, the first 34 years, I was asking myself, and I think they suspected this lymphedema. Maybe that patient had familial dyslipidemia. Therefore, she was exposed to the risk factor quite early in life. You need the presence of the risk factors, but you also need time. And therefore, you don't just refer the patient. When you are at the clinic, you see patients with chest pain who are being referred to the cardiac, a teenager, and then somebody will suspect, ischemic heart disease. They will request for ECG. They will not even ask the patient to bring the ECG or chest X-ray, and they will just send the patient to the cardiologist. We have to understand that you need the presence of the risk factors, and not only that, you also need time. It takes time for a significant atherosclerosis to form. And when they are formed, then the question is, are they stable or unstable atheroma? And when they are unstable, then that patient stands the danger of developing acute occlusion at any point in time. Not necessarily due to the atheroma, but because of fracture of the capsule and then formation of thrombus. And that usually brings the patient to you as a case of acute coronary syndrome. That is emergency, medical emergency, which might be managed well, but if you don't, usually you tend to lose your patients. The patient dies usually as a result of myocardial infarction. So the pathogenesis, as I've said, for acute coronary syndrome would occur when there is a complete occlusion, usually in the case of staining, or sometimes the occlusion occlusion may occur at the microcirculation level from thrombosis, microthrombosis. And these patients will present with chest pain which will last longer than usual if that patient is having stable angina pectoris. When they present with acute coronary syndrome, the pain may be the same, the nature may be the same as that of stable angina pectoris, but in this case it will last longer. And patients with stable angina pectoris, how do they present? They present with chest pain, which usually present as a discomfort, recurrent. And for some patients may even learn to the extent that they will know the level of exertion which usually precedes. And when they stop whatever they are doing, the pain goes down. So patients become used to that kind of pain. In some cases, the pain may be precipitated by emotional stress. And some patients who might have been given nitroglycerin by their doctors will also tell them that when I take it, the pain goes away. So when the patient has this type of pain, we describe that as a typical angina. And usually, in most cases, the diagnosis of coronary artery disease is definite. But it's very important to make this distinction about the nature of chest pain that the patient presents to you at the clinic. And you should always ask yourself, is it a typical chest pain, which is that I've just described, for patients who usually have stable angina. And this pain is relieved by taking nitrates. For patients with atypical angina, they have at least two of the above. And then we have patients who also have chest pain, which is classified as a non-cardiac chest pain. And when you take these patients through, the features of typical chest, one feature of a typical chest pain. I want to emphasize that any time that you are evaluating chest pain, you take your time and make these conclusions. At the end of the day, try and place the chest pain under one of these three categories. When you do so, and you do it very well, in most cases, you may end up getting to the root of the patient's problem. The non-cardiac chest pain are usually due to a number of things, and they have some few. And they tend to be very common, very common. Gastroesophageal reflux disease, esophageal spasms, esophageal rupture. Well, esophageal spasm is very common. You take your time and talk to your patient, ask more questions, but some of them end up having esophageal spasm. And then peptic ulcer disease. In some patients, maybe just musculoskeletal cause. And then we have pulmonary causes. And some patients also tend to have psychogenic, which is described as cardiac neurosis. We should take our time and try and categorize our patients' pain. Clinical pathological studies have demonstrated that it is possible to predict the probability of coronary artery disease on the basis of the history. And I want to be very emphatic, but history is very, very important. Take your time and take the history. Physical examination, in most cases, you may not find anything. But if you take your time and take a good history, at the end of the day, you will end up getting to the root of the patient's problem. And in taking the history, pain type, which I've talked about it emphatically. Age is very important. And why? I've just said it. You need time. In the presence of the risk factors, you need time. And it takes an average of about 10 years for a significant plan to fall. Gender is also very, very, very important. We have figures here, and this is just a summary of what I've talked about. Each value represents a percent, a significant percent of a patient significant coronary disease on catheterization. And these are patients presenting with these three types of chest pain: the non-cardiac, the atypical, and the typical. And you have the age, and you have the gender. Let's start from the top here. If a patient is less than 40 with a non-cardiac chest pain, the likelihood, this was, it was proven at Catalan. For women under this study, only 2. So even if you bring in the gender, somebody who is less than 40 presenting with chest pain, which is not typical, non-cardiac, the likelihood is far less. On the other hand, on the other side of the coin, typical chest pain in a male who is almost 70, or even a female, the likelihood is very, very high. So please let's consider age, let's consider gender, and take your time and categorize the chest pain. What kind of chest pain am I dealing with? Is it a non-cardiac? Yes, if it's a non-cardiac, it's a likelihood, but you have to weigh it, look at the risk factors, and then manage the patient accordingly. If it's a typical, and if it's a male, if it's a postmenopausal female, they are very close. But typical premenopausal, the likelihood again, when they are protected by the high presence of estrogen in their blood. And once estrogen goes down, the protection also goes down. It's not coming. Yes, this is the investigations that you can do in getting the diagnosis done, resting standard ECG, 12-lead ECG, and it's mandatory, but the sensitivity is quite low. Stress ECG is also very important. It has somehow higher sensitivity and specificity. Rest echo can be done, and again, stress echo can also be done. Then chest X-ray, but chest X-ray, especially in the acute setting, which we will talk about, you should always do a chest X-ray to rule out things like dissection of the aorta, because they can also present in the same. And then pulmonary problems like pneumonia and refuge. Chest X-ray is very important. And then, coronary calcium score. It's a form of screening test that is said that when you suspect it and you do it and you get calcium score of 0, the likelihood is very, very low. So you can also use that as a form of screening test. And again, as a form of screening, non-invasive, you can also do CT coronary angiography. Then the gold standard coronary angiography, and if there's a significant disease, you have coronary angiography, PCR can be done, stent can be passed, and of course, cardiac perfusion. Image can also be done. This something coronary angiography showing a significant contribution in the right coronary actual patients. Yeah, so let's talk about acute presentation. Acute presentation of coronary artery disease is described as acute coronary syndrome. And the acute coronary syndrome involves 3 categories of clinical disease, which are all acute coronary artery disease. But the pathogenesis and the prognosis are different. But despite that, the clinical presentation is almost the same, and that is the reason why this technology is required to cover these three clinical presentations. So it's a patient who will present with a typical chest pain, which will last longer than usual if that patient already has a history of stable angina. If he doesn't have this, which occurs in about 50% of people who don't have any history of stable angina at all, and that is possible because these patients may have plaques which may not be significant. And the plaques may not be causing significant complications. Yet, if they are not on proper treatment, these plaques may have unstable capsules, and therefore, even though the plaques may be there, flow may be okay, and the patient may be asymptomatic, these patients have a high risk of developing rupturing of the plaques for acute effusion to end, and therefore, patients without any prior history of angina usually present because of this specific reason. So you have these patients who present with severe pain, but the first group of stable angina are those with occlusion causing severe ischemia in the absence of necrosis. So they don't have infarction at the time of presentation. Even though they don't have infarction, with time some of them move on to infarction. They will present the same clinical picture as somebody with infarction. And then those with infarction, we have two categories of patients. We have those who would produce an ECG. When you do ECG, they will produce what we call ST segment elevation. They have a specific treatment, which is reperfusion therapy. And that is the reason why this group of patients with myocardial infarction who present as classified. Why? Because when you give them reperfusion therapy, they tend to improve their prognosis. And then we have this second group who are described as non-ST segment elevation myocardial infarction. Usually, these patients tend to have lesser infarction. Pathologically, most of them tend to have micro thrombi, causing occlusion, as opposed to those who present with STEM. Those who present with STEM tend to have large epicardiac arteries, re-occluded. So they tend to have complete occlusion and severe myocardial infarction and poorer prognosis. So for those with myocardial infarction, whether ST elevation or non-ST elevation myocardial infarction, they will have these symptoms which will present, which they will come with as acute coronary syndrome, and then ECG changes, and there will be evidence of myocardial infarction, which are the serum cardiac muscle elevation on presentation. I've talked about unstable angina already. Yeah. So whether it's unstable angina, non-STEMI or STEMI, the clinical presentation is seen, but as a clinician, as you work this patient out, you should be able to categorize them. So those with unstable angina will have normal cardiac exercise. At the time of presentation, they have severe ischemia, but no necrosis. Therefore, when you check their cardiac exercise, it's normal. Those with STEMI will have ECG changes, and because it's a myocardial infarction, you will have elevated cardiac enzyme, as well as those with non-STEMI. ECG is very, very important, and it's said that in fact, when the patient comes to the emergency room, within 10 minutes, if you can't interpret, get an ECG done within 10 minutes, you should get an experienced physician to do that for you, so that you'll be able to categorize your patient very well. So based on ECG, You may do an ECG which may appear normal, not significant. Some patients may present with ECG or changes like ST segment, depression, asymmetrical ST, T-wave inversion. And this is usually seen in patients with non-STEMI. And then patients with STEMI, ST segment invasion and having inversion will have this. See the ST segment invasion, V1, V2, V3. And then those who present this new left bundle branch block in our setting is a bit difficult. In places where patients' records are kept in the particular center, or they can even be sent when you request for these minutes. The patient comes, you see a left bundle branch block, a presentation, and then you ask for the previous ECG. And when it comes in the previous ECG, it didn't show left bundle. Then you describe that as a left bundle. Here we don't have those records, so describing this is somehow difficult. We may be wrong. So cardiac cancer, we have a number of them, but troponins are very specific. And they are very reliable. And now we have access to them, so we have to do troponins. And evidence has shown that prognosis after myocardial infarction is related to the level of troponins at diagnosis. So troponins are very, very specific, and we have to do them. So at the emergency room, you have just 10 minutes to assess your patient, get ECG done, and then as you are taking the history, you are doing the necessary examination, you do IVA assess. If you have to give oxygen after checking the saturation level, you give oxygen, you give aspirin, you give your nitrogen. Don't forget your chest X-ray. The patient may have a dissection of the aorta, and because you are going to give antithrombotics, you may cause more harm than good, and therefore you always rule out dissection of the aorta. Your patient may even have a respiratory problem, pneumonia or pleural effusion, so it's very important. And you should always look out for those with ST segment elevation or cardiac infarction, because they would require reperfusion therapy as diagnosis. So you should always look out for them. Okay, so let's look at the long-term management. After you have stabilized your patient, your patient will have to be on aspirin. And then those who undergo percutaneous coronary intervention, PCIs, you usually combine aspirin and clopidogrel for about 1 year. Then clopidogrel can be dropped. The patient is put on aspirin indefinitely. Beta blockers should be considered unless there's contraindication. And what are the contraindications? Bradycardia, significant bradycardia, and hypotension, and of course those who don't get sick. In the absence of contraindication, you have no reason why you don't put your patient because of the benefits that patients then obtain for beta blockers. ACE inhibition is very important, either with ACE inhibitors or ARBs. And then lifestyle measures, patients should be advised to quit smoking, those who smoke. Lipid management. Now we've even moved beyond just looking at the lipids, and we say that patients with coronary artery disease for secondary prevention, whether the lipids are normal or high, you don't look at the lipids there. You have to put them on high doses of statins. And these days we have these agents coming. The end point of their mechanism of action is the same as beta blockers, but they don't cause hemodynamic effects as we have with beta blockers. They are anti-ischemic agents. Yes, so those with other risk factors, you have to modify the risk factors. And these are the targets for the various risk factors. It's a secondary prevention. Now, in summary, angina pectoris, as I just classified clinically into typical, atypical, and non-cardiac chest pain. And it's very important that you approach evaluation of chest pain in this way. Acute pulmonary syndrome, presenting as stable angina, non-steady, should be evaluated within 10 minutes of presentation. And as I said, if you don't have access to an ECG or you can't interpret it, you have to make arrangement for the patient to be transported to centers where this can be achieved within 10 minutes. The most powerful predictors of the probability of coronary disease are the pain type, which we should pay attention to, the age of the patient, as well as the sex of the patient. Aggressive attention to primary prevention and secondary prevention is necessary in reducing heart disease.
Thank you.
Thank you so much, Dr. I'm sure you have a couple of questions you want to ask. But before then, we have these evaluation cards. I want to send them down. Just don't write your name, write your specialty, where you're from, and then just score a presentation. I think that's okay. Today, you'll be writing a lot of exams today, you are from market, so it should be So we'll send them around, everybody gets a copy. But in the meantime, get your questions ready. If you have a question, would you please get it ready for me? Any questions, please? You're welcome to tell me. It's good to have you here. You have a question at the back and the name is. If you mention your name.
Let's say acute coronary syndrome, particularly the last districts where we don't have facilities and most of the time they come in after several days of having chest pain and all that, and you still see ST elevations. Is there any window for intervention in that region? So do we have to send to you, or we try to manage mobility at our centers? And then some may come with limiting BPs, and just as we know, we have to put in the AC inhibitors and the beta blockers. Likewise, if we don't have significant pulmonary edema. In such a case, which one would we want to put in first? because we are thinking starting with maybe a low dose ACE inhibition and beta blocker. At the same time, they compromise the BP further. So which one would you choose over the other?
Maybe I will start with your second question, which is very important question. If you ask me that if for one patient between an ACE inhibitor or a beta blocker, the patient has to receive one. The patient cannot tolerate it. I will go in for beta blocker. For beta blockers can indirectly also cause the ACE inhibition. So I will go in for, and if it's, I will even do more in the setting of ischemic heart disease. Or if there's no contraindication, beta blockers are anti-ischemic. They are anti-ischemic in the sense that they reduce the heart rate, and in so doing, they reduce the workload on the heart. And as you know, the pathogen, in fact, we didn't have the time to go into this. There's always a mismatch between demand and supply, the setting of ischemic heart disease, and receiving so in the acute setting. And therefore, when you have such a situation in the heart, you shouldn't tolerate a higher heart rate. So you bring the heart rate down, and we usually say that you can do 60 or lower. Sometimes physicians are a bit afraid to bring the heart rate to even around 60. It has to be 60 or lower. So when I see these patients with heart rates of 70, I say they are not receiving adequate beta blocker. It has to come down for ACE anti-ischemic effects. So yes, that's what I will do. And I will even do that also for patients with heart failure. If they are hemodynamically unstable, you have to choose between an ACE inhibition and going which can do indirect ACE inhibition. Then later on, when the hemodynamic settles, we bring ACE inhibition. Your first question, yes, for patients with STEMI, if you want to preserve irreversible loss of cardiac function, you have to go with perfusion therapy. For medical perfusion, there's usually a review, and in our setting, most of we see patients beyond this review. We, as at now, we don't have setups here for PCIs. In the future, we are hoping that that will happen. And now, in Europe, where the PCI can be done, patients are receiving PCI and primary PCI. Once you diagnose, you have to do perfusion. If you see the patient before the week of 12 hours, you should always do it. If you can't do it, you have to refer to the person. You always remember that when you waste time, the patient tends to lose their vital and healthy function. And that should always happen.
Thank you.
Can I ask another one?
Make it a little more.
Okay, yes. And sometimes too, maybe somebody comes in an acute coronary syndrome. Sometimes it's quite difficult to get in the patients to Confanoche because of referral issues. You need to get an ambulance and all that. So it's difficult. And the person comes in with maybe a cardiogenic shock. And it's difficult to bring up the BP. Then your only inotrope available sometimes is dobutamine. And they are wondering, is that a safe option to give for somebody who is already having cardiovascular compromise? Do you want to start in dobutamine to bring up the BP? Or you want the BP being low, and what will you achieve with that? So then you are torn between this and that, and you don't know what to do. Especially if it is not a right-sided, right coronary artery form of MI. So you get confused as to what to do next.
Yes, I appreciate your concern. I think it's a big challenge. Even here, what you do here, you can't, somebody from my career fashion who is what you have to do is to try to balloon on this. That is what you have to do. And then really, we don't have to. So this is a very.
So in the absence of that, what do you do?
That's Africa.
Yeah, in the absence of that, what do you do?
It's a very big challenge. You can refer the patient to but you have to look at the patient, look at the patient and solve it accordingly. So it's usually individualized. One cannot make a blanket look at the issues and handle them accordingly.
Wow, thank you. So, thank you very much, Mr. Isaac. I think the man is pushing you to the wall. In the absence of a microphone, what do you do? Walk to the place. Anyway, forgive me for that, man. We are honored to have Akama speak to us. This is somebody who has, you can tell from the letters after his name that he has been in school for quite a long time. And then he's a consultant, interventional cardiologist. Now interventional is added to everything. If you don't do so, you are in trouble. So he's a consultant interventional cardiologist, board certified in the US. And then you must listen with some rapt attention. I hope there will be photos and videos so that we can understand it a little better. And those of us who can hear. So we shall put our hands together and welcome.
Okay, so we're going to have Microsoft fighting with Apple. That's what is presented with my computer. But I'm here in high-tech world. And now it's knocked my low-tech out. So we'll try and see whether some will play. So my name is Dr. Akama, Joseph Akama. I have nothing to disclose. I know we're tired, we're always. Some of you have been working since morning, and instead of going home, we're here. And the young ones, my one to them is Friday. Go hang out with some nice people and see what is going on. So, without much ado, let me just tell you what cardiology is now. In Ghana, we have maybe 12 cardiologists. 12, right? Kumasi has about half, Accra has half. 30 million people. 25 to 30 million people. The cardiology has grown into a big specialty. It's grown into a big industry. So if you're looking for money, if you're an entrepreneur in cardiology, if you're a lifesaver who doesn't want to supply in patients, then you look for more cardiologists. You have. I'm sorry. We compete, you see. Those of us here compete with him. But cardiology, now you can go into general cardiology and just zone into preventive cardiology. And then go to heart failure, transplant medicine, adult congenital heart disease, because usually it's pediatric cardiologists who look after congenital heart failure. But when they become 18, who is going to take care of them? And now they have complex heart disease, so you can't have a general cardiologist see all of these people. So now there's a subspecialty that you have specialized. You have critical care cardiology, where his job is to make sure that the heart transplant patient survives person who comes to the end shock survives. Then you have geriatric cardiology. Because now we're getting people living to 98 with pacemakers, still walking around. There's a WhatsApp video going around, and a 91-year-old nurse who's still working. Who's seen that? 91-year-old nurse still working. So such a person, if she gets chest pain, should the general cardiologist just see her? Maybe some people specialize in geriatrics, who understand that specialty. They have non-invasive cardiology, echocardiography. So we all do echocardiography in Ghana, but if you want to know echocardiography and do research in it, you have to stop everything and just zone in echocardiography. That's where they bring out the research tools. They bring assessment tools. Most of us are doing pa. There's no time. Okay, there's no time to do research in echocardiography, but that person's job is just echocardiogram. He wakes up, he thinks echocardiogram, he goes to sleep, echocardiogram. Then he can spit out some tests. And then you have nuclear cardiology. Then you have invasive cardiology. Some people want to go into the heart, but they don't want to intervene, so they call themselves invasive cardiologists. Starting all over. Okay, then you have the physicians. So their work is just to look at electrical current inside the heart. And right now, in top level countries, they pick them very young because it's a very tough area. They pick them very young, 2 years in internal medicine, straight to cardiology, 2 years straight to EP. When they come out, all they think is electricity of the heart. That is it. Nothing else. So if you tell them to read this ECG, calculate whatever, they can tell you how many milliseconds, they can put a pacemaker in you, and your heart will kick like it used to kick. So these are specialties. Then you have the best people, the plumbers. The plumbers. Without a plumber in your house is in trouble. You know that, right? If your toilet is blocked, you need a plumber. If your sink is blocked, you need a plumber. So this is how cardiology has grown. Then you have pediatric cardiology. Now mirror images, apart from the geriatric, okay, everything else there is happening in pediatric cardiology. This is how wide cardiology has become. Okay, this thing goes back to 0. So maybe I'm pressing on something. Yeah, I think I was pressing on something. So, interventional cardiology, the topic I'm talking about is it necessary in Ghana? Where they have instituted interventional cardiology, there's improved outcomes. Live longer.